I think this when to give monoclonal has been told clearly by Dr. Jagdish. Between 3 to 7 days after RT-PCR becomes positive. What about patients who are already seriously ill in the hospital? Can we give it to them? We are now doing a study. There is some studies saying that if the patient is seriously ill, that is beyond the 7 days, he is in ICU on a ventilator. In these patients, if the body does not have antibody against the virus, then we give large dose of this monoclonal antibodies. We are giving a very high dose of at least 2.4 grams now, and we are studying this to see whether efficacy is there in that group also. The most interesting thing is, can it be used as prophylaxis? That is, you don't have the disease, but you're not taken the vaccine, but your family member is having the disease. In the family, one person is having, there are 5-6 family members. Vaccine effect takes at least 1 month. So immediately can you get a protection? Yes. Recently, just about 4 weeks back, a paper was published in New England Journal where this was a study from US where they given this monoclonal antibodies subcutaneous to family members of infected people. And it is shown very clearly that if you can take it as a prophylaxis to prevent this virus from attacking other family members. So suddenly, you're not taking the vaccine, suddenly you have to go to a place which is full of infection. You can take a subcutaneous dose of this monoclonal antibodies. You will be protected for at least 3 months. Of course, nowadays we want everybody to take the vaccine, so that is a better method rather than, but for some urgency, if you want to be urgently protected within the next 2 or 3 weeks, this subcutaneous injection is extremely useful. So just to summarize, I think this was a collaborative study from these 3 major institutions which has shown for the first time that monoclonal antibodies are very effective against Delta virus. It has to be given within 7 days. None of the patients became serious or developed there were no deaths in the patients who took this treatment. Although this is a very effective treatment, the cost factor has to be considered. It's costing about 65,000 rupees for a single injection, only single injection, no hospitalization is required. It is very important that only patients at high risk who develop this should be given the injection, who are likely to become serious. 95% of the patients who are not likely to be serious, who are not in the high risk group, don't require this injection. Very important. Everybody should not be given just because what we are worried is after this paper is published, all the doctors will say, okay, we'll give it off to everybody. This should not be done. Only for those people who are in the high risk group, this monoclonal antibodies can be given. But I think the future is very, very bright in terms of this being given as a subcutaneous injection and so on. A lot of new studies, and recently a study has come in England where a single monoclonal antibody, not the cocktail, single also is used quite effectively, and then it becomes very cheap. So probably this therapy will evolve more and more as we go on. And again, on behalf of the AJ, I'd like to thank our partners CCMB and Life Science Institute for this very high level of scientific work which was done to showcase what can be done in our country also in terms of doing clinical studies to show the efficacy. The difference between vaccine produces antibodies, but vaccine produces a lot of antibodies, different types of antibodies, not just one monoclonal type. Second, vaccine, when it starts producing antibody, it takes minimum 4 weeks, usually 45 days, that is 15 days after the second dose. Whereas here you are giving a direct injection of monoclonal antibodies which are very highly specific against the receptor binding domain of the virus. So it's instantaneous effect. It's like giving an instantaneous vaccine. That's the thing. It's very, very specific, doesn't produce other type of antibodies. The second thing is that rejection does not occur because these are humanized. These monoclonal antibodies can be humanized antibodies or can be produced from the animal source like rabbits and so on. Those are the ones which produce reaction. The humanized ones don't produce. So these monoclonal antibodies do not have any rejection or reaction. None of the patients develop any anaphylactic reactions, and although this is an antibody. So we are following them up. The immunity that it provides, the monoclonal antibody prevents infection for 3 months. Till 3 months they don't get reinfection. Now after 3 months, the reinfection rate will be equivalent to what normal population is, but many of them have already taken the vaccine after 3 months. So what we advise is, you take monoclonal antibodies, exactly at the end of 3 months take vaccine. And then vaccine protection starts. To our obese children, if the BMI is more than 35, if they develop the infection, then it's good to give this, it protects. So these 2 categories of children we have to give. we continued, and now we have completed 1,000 cases now. Actually, little over 1,000, and the results are same, exactly same. There's no
severity, no progression of the disease.
No progression to severity. None of the patients had severity. No deaths in this 1,000 group. And most important, I feel, in long term, the post-COVID syndrome also goes off, because the post-COVID syndrome is because of body's reaction against this virus. Lot of auto antibodies are produced once the virus enters into the cell. Because this monoclonal antibody prevents the virus from entering into the cell, all these phenomena don't come. And this is the most important benefit, I think.